Hello, everyone. Thanks for joining me for Part B, Licensed Clinical Social Worker, Common Rejections and Denials, a webinar designed for those who submit claims on the CMS 1500 claim form or the 837P electronic claim. My name is Mary Moko, and I will be your speaker today. Assisting me is my friend and provider outreach and education colleague, Ellen Vera. We include this disclaimer in all our education, and we do so to remind learners that although we made every attempt to provide current information that is correct, the information is indeed subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And just as a reminder, CMS prohibits recording of this presentation for profit-making purposes. Now, just as advertised on our website and in our news items that went out, I will be providing details today during this webinar on common rejections and denials for licensed clinical social workers, and how to fix and avoid both. I'll also include some helpful resources for learners, and the event will conclude with answers to learners' presentation-related questions. I did send an email yesterday to registrants to let them know that if you have questions other than these topics that we plan to cover today, there are resources available. I included that information in the email that I sent, and I also provided some information about how you can ask non-presentation related questions. Those go to customer service. Let's begin this presentation then. With the life of a claim, in order to fully understand rejections and denials, it's really important that you recognize the path that a claim takes, or what we like to call the life of a claim. This is a simplified graphic on how a claim gets into the Medicare claim system. Of course, the provider would render the service, submit the claim, and the system rejects the claims if necessary and provides information into a report by the name of the 279 or 9099 report. This slide expands really on what that graphic on the previous slide is meant to depict. Most providers submit electronically. Very few qualify for a waiver under a law that prohibits payment of services or supplies that a provider did not bill to Medicare electronically. Now, to confirm claim receipt, providers should use the 999 report, and you'll see that I've linked to the companion guides for both the 999 report and the 277 report here on this slide. Correction, this actually links to the 276, 277 companion guide. Use this 277 report for more specific information about the claim. Our electronic data interchange, or EDI staff, provides helpful information in that companion guide, and this will help clarify and further define the data content requirements for an electronic claim. And it is based on these reports that you will know whether the batch is rejected and if you need to correct or resubmit. Here's a simplified graphic that shows what happens to the claim that Medicare deems as unprocessable. An unprocessable claim is also known as a rejection. The provider renders the service, submits the claim, but something on that claim is invalid. It's in an incorrect format, incomplete, or simply illogical, and that information is conveyed on the remittance advice. Here's a slide that compares a rejection to a denial. They really are very different things, and it's important for you to recognize that. I think some of us use these terms interchangeably, and we really shouldn't do that because they are very, very different. A rejected claim is one that's unprocessable. It's not processed, it's not adjudicated. It's returned on what we call the front end. It's missing or something's incorrect or illogical. There are no appeal rights for a rejected claim. You need to fix it and resubmit it. Now, there are codes that appear on the remittance advice, which I'll talk about in just a moment, and they're listed here. For rejected claims, you will see the MA130 or the CO16 on the remittance advice. That conveys information to you that the claim is rejected. It's not or it's unprocessable. You do not have appeal rights for these because they're not adjudicated. The patient is never liable for a rejected claim. Now you compare that to a denied claim where the claim is actually adjudicated. The services deny because the line item or the claim itself fails to meet payment criteria. Now, these may take the form of denials due to statutory requirements, and what that means is that based on the law, the service is not covered by Medicare. The denial may also be related to medical necessity or frequency parameters. Frequency parameters are a form of a medical necessity denial. And remember, for those services, those denied as not medically necessary or because of a frequency edit, you need to consider presenting your patient with that advance notice or advanced beneficiary notice of non-coverage, or what we call the ABN. Other denials are due to eligibility, and this may be eligibility as it pertains to the beneficiary or your patient or to the provider. Now, sometimes there are eligibility reasons why a claim is rejected, but there's also denials based on eligibility. So I've included that here under denials. Now, for most denied services, appeal rights are available, and the MA01 message will appear on the remittance advice, or the RA, sometimes called the remittance notice, and that explains that patient liability will be determined based on those appeal rights. Remember that the remittance notice, or the RA, does include codes to explain the rejection or denial. This graphic then shows the path for a processed claim. Again, the provider renders the service and submits the claim, and during claims adjudication, the claim is either paid or denied, and then a remittance advice or remittance notice is generated. I want to talk about the importance of that remittance advice, or the RA, also known as a remittance notice. Most providers receive an electronic remittance advice. The acronym for that is ERA, as opposed to the standard paper remittance, which is the SPR. Now, depending on how the claim is processed, it may include information about any adjustments made to the claim or denials. And it could also include information about something that's missing. Sometimes it provides notice about refunds or even offsets. The ERA provides payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank, or the explanation of benefits or remittance notice. Now, if you have the understanding the remittance advice communication or publication from CMS tucked away in a drawer some way because it was really a great tool, you need to discard it. The CMS remittance advice overview booklet is no longer current. It's no longer available. So if you have a printed copy, you need to discard it. Instead, CMS now makes that information available, that information about the ERA and the remittance advice, right on their website. I'm going to ask Ellen to place a link to the healthcare payment and remittance advice webpage in the chat, and it is this webpage that takes the place of the previous CMS publication that I'm guessing many of you have looked at in the past. I want to talk a little bit about the claim adjustment reason and remark codes that appear on the remittance notice. Claim adjustment reason codes, we call them CARCs, explain why a claim paid differently than it was billed, and remittance advice remark codes, or RARCs, provide more details about an adjustment that's described by a CARC. Another type of code that appears on the RA is a group code, and these convey the financial responsibility for any unpaid portion of the claim balance. Now, a CO stands for contractual obligation, and that means the provider is liable and can't bill the patient. A PR stands for patient responsibility, and that, of course, would mean the patient is financially responsible for that service. You can find code lists on the Washington Publishing Company's website. It is this contractor that maintains the CARCs and RARCs and group codes for CMS. Now, WPS does understand that some of those codes may be rather cryptic or even out of date, and I'll show you some examples of that later. One example I can tell you right offhand while thinking about it is that some of the reasons that generate on the remittance advice include outdated acronyms. One is HICN, which stood for Health Insurance Claim Number. We all know that the Health Insurance Claim Number has gone away and has now been replaced by the Medicare Beneficiary Identifier, or MBI. WPS is unable to change those code descriptors. It is this company, the Washington Published Company, that maintains those codes. Should you have comments to share with that contractor about those error codes, you can go to the website. I've included the link here, and send that information on directly to the Washington Publishing Company. After reviewing your remittance advice, you're going to need to choose an action to take, and there are multiple actions to choose from depending on whether your claim is a rejection or denial. For an unprocessable or rejected claim, you're going to need to fix the error and resubmit the claim to Medicare. Now, if the claim or claim line denied, there may be multiple actions you can choose from. You may, for a denied claim, be able to simply resubmit the service. You might also be able to use a process called a clerical error reopening. CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'm going to talk more about that process in just a couple of minutes. Another potential action to choose from is an appeal. The remittance advice will provide appeal rights for those denied claims. I'll discuss appeals a little bit later in this webinar. Now, registered users of our transactional portal, that's that secure side of our portal that you can log into from any page on the WPS GHA website, is available to render a clerical error reopening or to request an appeal. And these self-service tools really do offer the most efficiencies when you're beginning to take those actions. Our portal user manual provides illustrations and step-by-step instructions on how to use these portal features. The next portion of this presentation delves into whether you need to correct or appeal the MAC's decision to pay or deny a claim. I talked earlier about the clerical error reopening process, and I told you that I would share more details, and I'm going to do that now. This is a process to correct those human or mechanical errors. These errors are limited to errors in form and content and omissions, and these do not include failure to bill for certain items or services. Now, there is a very helpful resource. I've included the link here to that in the last bullet on this slide, available on our website, that provides examples of which errors or which clerical error submissions are acceptable to render as a clerical error reopening and which are not. Now, some examples of acceptable reasons to render the clerical error reopening is a mathematical or computational mistake, perhaps a transposed procedure code, even a diagnostic code. Maybe there was inaccurate data entry, misapplication of a fee schedule, or simply a computer error. Now, in that resource that I've linked to, there's also examples of situations that cannot be processed as a clerical error reopen, and these are included in that resource. Now, your handout includes that link. The link is on this slide. Remember that you can use the portal for self-service clerical error reopenings, or you can simply request a clerical error reopening via telephone or fax. And of course, that portal user manual does provide instructions should you choose to render this yourself. For claim denials, most often you can request an appeal, and the remittance advice will provide that notice to you. The purpose of the appeals process is to ensure the correct application, or excuse me, the adjudication of claims. Physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by MACs. MACs are Medicare Administrative Contractors like WPS-GHA. The beneficiary or their representative may request an appeal on any service that's processed for them, but providers and suppliers can appeal services for which they accepted assignment. There is a couple of exceptions though. For unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement. An example of that is a CMS 1696 form. This is the appointment of representative. In addition, a provider or supplier can request a redetermination, the level 1 appeal, on an unassigned claim if Medicare denied the service as not reasonable and necessary, or the provider or supplier billed in excess of the limiting charge, and the provider or supplier must refund any fees collected from the beneficiary. The first level of 5 in the appeals process is called a redetermination. It is the only level of appeal that is rendered by a MAC. Time frames apply to each level of appeal when submitting them. And additionally, there's a minimum amount in controversy that applies to levels 3 and 5. In order to meet that amount in controversy, you can combine like denials on more than one claim. That is in order to reach that amount in controversy. You can check out a great resource called How to Appeal a Claim Determination on our website. Here is a link for it. It's included in your handout materials. And remember that we do recommend using self-service options for more timely processing. I've also included on this slide one of my personal favorite CMS publications. It's one that they update yearly. It is the CMS Fee-for-Service Appeals Process Flowchart. And it is a flowchart designed to depict those 5 levels of appeal for fee-for-service Medicare claims. I like it because it not only includes the time frames that a provider or the beneficiary has to request that appeal, but it also includes the time frames that that contractor has to make their appeal decision and inform the requester of that decision. So lots of time frames there. It also includes those amounts of controversies. It identifies each contractor or each level of appeal. So a lot of great information at a really quick look at that flowchart. So I do recommend that you take a look at it. And again, CMS does update this annually. Sometimes those amounts in controversy can change from year to year. So you'll want to pay attention to the date that CMS updates that flowchart when you're using it. All right. The next portion of today's webinar, and just as advertised, we're going to share with you the most common rejections and denials. Our data informatics team known internally at WPS as Insight, developed a data dashboard so that provider outreach and education team members like myself and like Ellen can pull needed data for education. In their internet-only manual, CMS directs that the MACs are to provide education to the provider community about rejections and denials so that providers can fix or correct them or avoid them in the future. Now, this dashboard allows us to choose from certain items to view results, and it does so in just a matter of seconds. The data that I'm sharing today is all Specialty 80 submitted claims for Jurisdiction 5, which is the states of Iowa, Kansas, Missouri, and Nebraska, and Jurisdiction 8, which includes Indiana and Michigan. So all 6 of those states collectively. While the dashboard does allow us to drill down by a specific state or states and even counties, I pulled data for our entire jurisdiction. For those of you that are wondering what Specialty 80 is and what I'm talking about here, it's a 2-digit specialty code that is assigned to providers when they enroll. During enrollment, providers self-designate a specialty. While a provider can designate a secondary specialty, it is only that primary specialty, the one self-designated during enrollment, that is used during initial claim processing. There are some situations where a provider will request an appeal and stipulate or tell Medicare their secondary specialty in order for Medicare to make payment. But when a claim is initially processed, it's processed based on that primary specialty code connected to that provider number in our Medicare eligibility files. So that means when a claim comes into the claims processing system, if there is an 80 specialty assigned to it, the computer recognizes that that claim is a clinical social worker claim. Licensed clinical social worker claim. So I pulled claims submission dates September 1, 2023 through December 1 of 2023. That data was last refreshed on December 12th. So any claims that were submitted for this date range after December 12 will not be included in this data. You may be wondering why I looked back to September through December. When I prepared this presentation and put it through the review and approval process, I had to look at what was available at that time and keep in mind, of course, the time that I needed to allow for the review and approval process, and then, of course, publishing of these handouts. So, or the handout materials, that is. So these submission dates, or the information I'm talking about next, is September through December 1st of 2023. Let's take a look first at the top rejections by reasons. And remember, those reason codes that I've copied onto this slide are not those that are written by WPSGHA. Rather, they are owned by the Washington Publishing Company. The top rejection by reason during that time period for clinical social worker claims or licensed clinical social worker claims, Specialty 80, for WPSGHA, all states, all 6 states, Jurisdiction 5, Jurisdiction 8, is that the claim should have been sent to the Health Maintenance Organization. 1,961 claims during that 3-month period. This means that instead of sending the claim to WPSGHA, the claim should have been sent to the Medicare Advantage plan. So this then is a rejection that you can avoid by checking the patient's eligibility. I'll talk in a little bit about how you can do that. The second one is a little bit more cryptic. The claim lacks information needed for adjudication. 739 claims. You're going to need to look further at additional reason and remark codes to determine what it is you need to fix and resubmit. That is 739 rejections. The next one, and remember I talked a little bit earlier about differentiating between rejections and denials. I have to laugh at this one a little bit, or kind of chuckle. This denial, or excuse me, rejection reason actually prints out on the remit notice Denied. Field 11 of HCFA 1500 must be completed. Well, it's not really denied, it's rejected. And field 11 of the HCFA 1500, it's no longer a HCFA 1500, it's the CMS 1500, must be completed. And by completing this item on a claim, the physician or supplier acknowledges having made a good faith effort to determine whether Medicare is the primary or secondary payer. This is a required field. You have to fill something out here. So if there is no other insurance primary to Medicare, you need to write none in that. The instructions for filling out a claim form are included in CMS Internet Only Manual, Publication 100-04. I'll show you that resource a little bit later. I included the link in your handout materials. It goes field by field of a paper claim, CMS 1500, what you need to put where and when it's required or situational. There is also a crosswalk that WPS Electronic Data Interchange has made available that looks like this. I'm going to pull this over to you. I actually went out to that document before the webinar today, so I'd have it ready. This is that crosswalk, and here's where you can see field 11. So this tells you if it's item number 11 on a paper claim, what do you need to put where on an electronic claim? And is it situational or is it required? Okay. So good information. This is a fantastic tool, and it's called the HIPAA Electronic Claim Submission Requirements, CMS 1500 to ANSI 837-5010 crosswalk. This is a great tool that takes you item by item on a paper claim and crosswalks it to the electronic claim. So another great tool available. The link to that is included in your handout materials. The next item, top rejection, oh, excuse me, I clicked too quickly here. Got to get my mouse working. Rendering physician number invalid or missing. This is an easy fix. You need to correct this and resubmit the claim. Maybe it's invalid because it was transposed. Maybe it's simply missing. 379 rejections. The next one, diagnosis code missing or not linked. Don't bill the patient, submit a new claim. 208 rejections. Again, pretty much self-describing that error. That it tells you you need to submit a diagnosis code. All right, or link it. The next top rejection, claim submitted or claim must be submitted to RRB. RRB is how it prints out on the remittance advice, so that's what I've included here. RRB is Railroad Retirement Board. So once again, this is a rejection that may be avoided by checking patient eligibility. What you're going to want to do is, of course, ask your patient, can I see your Medicare card? You should do that every time they come in. Things do change. If the beneficiary is a railroad retired beneficiary, it will say Railroad Retirement Board in a banner on the bottom of their Medicare card. Next top rejection, patient insured HICN. And again, I told you there's some outdated abbreviations in these reason and remark codes. HICN is no longer valid, but it is the Medicare beneficiary identifier, and name do not match, and these need to match exactly. So take a look at the patient's Medicare card, look at eligibility in the self-service tools that are available to confirm that the health insurance claim name does match the information on your claim. Next, invalid or missing modifier, and I want to talk about that a little bit. And let you know that if you get this type of rejection or any denials that are related to modifiers, I'm going out to the WPS GHA website. I had this pulled up, but moved away from it and it went away. You could do a simple search on our website for modifier information. I'm going to choose just J8. We have a modifiers webpage out on our website, and we include fact sheets for most all of the modifiers that are available for you. So you might want to take a look at those for help in determining those situations that for which a modifier can be used, when it's appropriate and when it's not appropriate. These are great tools that will help you determine whether or not use of a modifier is relevant. All right. Invalid, incorrect ICD-9 code, resubmit a new claim. Make sure you haven't transposed that diagnosis code. Maybe it's not a valid code at all. Maybe it's missing. Next, missing information needed to adjudicate the claim. So the claim was rejected. And then finally, another common rejection reason, not all, I just included the most common ones out here for this presentation, is that exact dates and charges are needed. You need to rekey that electronic claim. Perhaps the date was submitted in an incorrect format, and so on and so forth. All right, let's take a look at top rejections by HCPCS code or CPT code. No big surprises here because these are all claim CPT codes or HCPCS codes that are submitted often by licensed clinical social workers. You have your psychotherapy codes. There is an originating site facility fee, that's that Q code. Interactive complexity is in the 90785. Also, 90791, and I know this is of great concern to many of you because there are often rejections or denials pertaining to this code, 90791. There is a frequency parameter for this code, 90791, and also the 90792, which is not billed by a licensed clinical social worker because it includes medical evaluation. The 90791 is only allowed once in each 6-month period, and that information is included in our billing and coding article that accompanies the WPS GHA policy L34616 for psychiatry and psychotherapy services. And I'm trying to pull that up for you here, and I'll just pull it onto your screen here in just a moment. If you're looking for information on frequency rejections or frequency denials rather, or rejections for this code, I'll show you where you can find that information. This is a look at our local coverage determination. You can see it's WPS's when you look under contractor information. Make sure you click on each of these because they do expand and provide additional information. For most every local coverage determination, near the end, you're going to find a link to a related local coverage document. It's the billing and coding guidelines that pertain to this local coverage determination. I'm going to click on that link and open up, and you can see that this is where WPS explains right here that this service, a psychiatric diagnostic evaluation or psychiatric diagnostic evaluation with medical service, can be conducted once at the onset of an illness or suspected illness. The same provider may repeat it for the same patient if an extended break in treatment occurs, if the patient requires admission to an inpatient status for a psychiatric illness, or for a significant change in mental status requiring further assessment. This is where it states that we will pay for this once in every 6 months. Now, if one provider bills the service and another provider bills the service within that same 6-month period, the second claim that comes into Medicare will not pay. Okay, or will not process. So you need to keep that in mind to avoid this. Ask questions of your patient. Make certain that someone within your organization isn't also providing this service for a patient. And remember that this is a medical necessity parameter. Medicare, when you look at a local coverage determination or any policy, it really does define medical necessity. So if you believe that the likelihood that Medicare might not allow this service due to medical necessity reasons, that would be a denial, you need to consider presenting your patient with that advanced beneficiary notice of non-coverage. You don't always know, and I know that it's sometimes difficult to know if someone else has rendered this service within a 6-month period. but you do need to do the best you can to determine that, or use the ABN in order to make certain that you're not liable for payment to the best of your ability. One of the questions that I just had about this service recently is, well, if Dr. A was seeing the patient and rendered this service, but Dr. A is leaving the clinic and Dr. B is now going to be seeing this patient. Dr. B wants to do the psychiatric diagnostic interview evaluation. It's within the same 6-month period. Is it allowable because it's a different provider? And the answer is no. This states we're going to allow it once at the onset of an illness or suspected illness or XYZ. You need to look back to this documentation here. Medicare doesn't consider it medically necessary to do this service again simply because you're switching providers. Okay? All right. I'm going to move that back out of there and move on. We're still talking about rejections here. I kind of talked about overlap on that service, the 90791 for both rejections and denials, because we do get a lot of questions about that particular service, the diagnostic interview, psychiatric diagnostic interview exam. All right, here are top denials by reason. Service not covered when performed, referred, or ordered by this provider. 2,591 denials. Make certain that you're paying attention to state scope of practice. Medicare will consider the service when performed by a licensed, an enrolled licensed clinical social worker, but you do need to be rendering services under your state scope of practice. You do need to be eligible to perform or refer that service or order that service. Duplicate charge paid on such and such a day on claim number. That means we've already paid for the service. Make certain you are not just automatically resubmitting a claim every 30 days. Keep in mind that Medicare has a payment floor. We have to hold payment for a certain amount of time. So don't just automatically resubmit your claims if you haven't received a remittance notice for that item or service. Next up, Medicare will not pay for this service for this condition. That's typically related to the local coverage determination. When you are looking at information for psychiatry and psychology services, I'm going to move the coding and billing article back over here. Remember that the local coverage determination is going to provide the coverage and indications for coverage for psychiatry and psychology services, but a while back, based on a law, CMS directed all of the MACs to take codes out of the local coverage determinations, but they're still available sometimes in the coding and billing articles or billing and coding articles. So I want to show you very quickly. Here are the Group 1, see it says Group 1 codes here under coding information. Here are CPT HCPCS codes governed by the policy. They're all listed here. And here are the Group 2 codes. That's actually only one, hypnotherapy code. And then right here, it tells you these are the ICD-10 codes that are covered for Group 1. And there's pages and pages and pages. And of course, you can use your Control F or your find to find a particular ICD-10 code to see if Medicare, WPSGJ specifically, because this is a local coverage determination, to see if we will cover that service. So, this is where you find that information and how you can avoid these types of denials. All right, next up, the time limit for filing your claim is expired. There's no appeal right. You have up to 1 year from the date of service to file your claim to Medicare. After that, if you file a claim, the claim will deny and there are no appeal rights. If you believe you have a reason for Medicare to waive timely filing, there is a process you can take. It's included on one of my slides. It's a resource that's available on our website that explains what you have to do if you want Medicare to waive the timely filing limit for your claim. You actually have to send some evidence in a letter to the claims manager to request that timely filing be waived. CMS is very strict on the guidelines for allowing us to do that, so very often we do not waive the timely filing limit. Next, sorry, went too far here. I scrolled. I apologize for that. Oh, I'm gonna go ahead. Sorry about that, folks. Procedure, I'm getting my head of myself here. Procedure modifier was invalid on the date of service. So make certain that the modifiers that you're using are valid for your date of service. Physician not eligible to receive payments, physician or supplier that is. So for something like that, you'd want to pick up the phone and give a call to customer service. They'll patch you through or get you through to the provider enrollment analysts that are available in customer service to help you. Services are denied because the patient is in a hospice. This is a situation where you're going to want to pay attention to Medicare eligibility. There's tools that you can use to avoid these denials. I'll be going over those in a bit. Medicare does not pay for this service by this provider. Again, this would be an indication that Medicare doesn't pay for this service because it was rendered by the licensed clinical social worker. Medicare does not pay for this many services in this time period. That's a frequency parameter. What you'd want to do there is consider presenting your patient with that ABN if you believe that Medicare may not pay for the service. And the last of the top or the most common denials by reason based on that data poll that I did is that the claim needs to be sent to the employer group health plan or it should be LGHP. I apologize. That's a typo there. HGHP should be LGHP, which stands for Large Group Health Provider. This is a Medicare secondary payer denial. We have a lot of resources on our website. We have a lot of YouTube videos that explain how to bill for these Medicare secondary payer situations. Here are top denials by HCPCS code or CPT code. Mostly the same. We have your therapies, your 90791, that diagnostic eval, and so on and so forth. So just thought you might be interested in that. Now, I told you we have different parameters to break down. We can break down this data by specific state or by county, by reason or by code. We can also take a look at trending, and I want to talk about that for just a minute. We can trend both unprocessables and denials, and in fact, it's CMS's expectation that we do that. This is what we look at or what we can look at, and I placed right here an actual example into a denial. The code is 158. Medicare will not pay for this service for this item or condition. It gives us the trending report, gives us the count for the current 3 months, the count for the prior 3 months. It's going to give us the difference in claims. It will give us the percentage in claims. And then when this report prints out, there's arrows that point up if we've gone up or down. So this is a way that we as a MAC can monitor, the trending of a particular denial or rejection. And again, CMS expects that we be looking at that and providing education, which is exactly why I designed this webinar for you specialty 80 providers today. I mentioned to you that there are many tools you can use while I was talking about the rejections and denials, and this just provides for you those resources of things I've talked about. I talked about the claim form instructions in the IOM, the Internet Only Manual, and that crosswalk. This is shows you requirements for Medicare claims. So if your rejection or denial is done so for these reasons, that something wasn't on your claim or invalid or incorrect, you can look there. This is a great resource on our website that lists by those reason and remark codes that I talked about, the CARCs and the RARCs, how to correct your rejected claim. So this provides you with a listing of codes and says, this is what you need to do to fix and resubmit the claim. Here is a WPS resource that uses various categories for denials. Again, listing by reason and remark codes for categories such as bundling or global surgery or payer or contractor denials, entitlement denials. It's a great resource for you that lists by these categories how to, the actions you need to take for these denials. Here are other resources. One of your common denials was due to service the patient being enrolled in hospice. So I've included that resource. I've included MSP resources. The live events webpage tells you future events we're hosting. Encore presentations are those recordings. And then of course we have the lookup tool for local coverage determinations and our YouTube channel as well. All great resources for you to help you with those actions to take for rejections and denials and really to avoid them in the future. The modifiers webpage is here. Timely filing of claims. I told you I would show you the resource later where you can find step by step what you need to do if you wish to request a waiver of Medicare's timely filing for a claim that was denied. And of course, we have provider enrollment guides and resources for those rejections or denials that pertain to the provider number itself or provider eligibility. The Medicare coverage database is that national searchable depository of the national and local coverage determinations. This will help you determine what's medically necessary, what's not. There is a great tool CMS makes available that helps you learn how to use that coverage database. And then, of course, I've included information about the beneficiary notice initiatives that talks about that advanced beneficiary notice of non-coverage, a form you need to consider presenting to your patients when you believe the likelihood that Medicare will deny the service is not medically necessary. For eligibility, you'll want to consider using the interactive voice response. This also provides claim status and details about the claim. You can use voice or telephone keypad. We have instructions in the IVR operating guide. This tool is available 24 hours a day, 7 days a week with some limited functionality outside normal business hours. Very, very similar to using the portal for the same type of information. However, the portal gives you even more details than the IVR does. There is a more information button when you're looking at claim details that allows you to view greater details. And let me give you an example of that. If your claim denies because of frequency parameter or something that was in the or should be in the policy, more often than not, this more info button is going to allow you to link directly to that particular policy. So it offers some great functionalities to really help you understand the actions you need to consider taking to fix a rejected claim or to appeal a denied claim or to avoid them in the future. We have the portal user manual that provides illustrations and instructions for those of you unaware. There is, we just redeveloped our website. We are now working on the redevelopment of the transactional side of our website, so the portal. Everything that's there now is still going to remain there. It's just going to look a little different and hopefully be more user-friendly because we used your survey comments and feedback in order to make these updates. So we have a team of folks, of course, working with the developers on that. We hope to roll that out in mid-April. And just as a reminder, use of those self-service tools, especially those two that I just talked about, are really often the fastest way to take corrective action. All right, that brings us to time for questions. Ellen, I'm going to reach out to you and ask you if there are any presentation-related questions, those on rejections and denials, how to fix or avoid them, that I can help with.
Sure, Mary. The first question comes from Lacey, and she's talking about missing information denials. And the question is, does the full treatment plan have to be with each progress note, or can it be referred to, such as the date the treatment plan was documented?
You can refer, that's a great question. This really doesn't pertain to rejections and denials on the front end, but potentially on the back end, because in order to know the information is missing in that documentation, we need to be looking for the documentation. However, I should correct myself and say that sometimes we do develop on a claim on the front end, and there should always be a reflection of where to find that treatment plan in the note. And let me give you a tip too. So if a treatment plan is written on June 1st and the service you're billing is on July 1st, and you refer to that treatment plan back on June 1st in your July notes, when you submit your documentation to Medicare, you need to include that treatment plan from the June 1st service. So you need to send it along. But it's okay to refer back to it. But if you're asked for documentation, you're going to need to submit it. Great question.
Okay, the next question that we had is why is the 90837 so often denied?
Well, that's a good question. What I would have to do is actually pull the specific data for that in order to in order to ask that. I could do a little digging and get more information back to you on that if you wish. If you do wish, I'm going to tell you in just a few minutes how you can submit questions to to me following this event. So stay tuned for that. I can't honestly tell you right now why that one is so often denied, but I can dig deeper and find that information for you and provide it later.
And Mary, wouldn't that, because that code showed on both your rejection and your denial list, isn't it possible that that's simply the more common code that's also billed by this specialty?
That sure can be one of those reasons. And you'd have to look to, of course, our local coverage determination to see if there are any specific guidelines for that code. In fact, I'm pulling this back up. This is the billing and coding guidelines, and I'm going to key the Control and F and look for that code specifically. This is your 60-minute code. So Ellen, your point about it being a very commonly billed service is a good one. It's 60 minutes of psychotherapy. Uh, I don't know why 60 minutes would deny more often. Of course, if it's billed more often, it would, as opposed to another. But this is where you can find guidelines for psychotherapy in the billing and coding guidelines. Okay. Also in the policy itself, and I'm going to move this over and pull the policy back. If you're billing for psychotherapy, there's some great information right in the policy about it, the expectations for WPS GHA, and why or why we would not pay for that. Let me just find it here. These are the revisions. Um, Move this up so I can see a bit more. I'm going to scroll, so if that bothers you, look away. I'll warn you. Um, Here's the LCD information. Diagnostic. Here is some information on psychotherapy right here. Maybe it's because the psychotherapy is being billed with something else on the same day, which is making the psychotherapy also not covered on the same day. There is some bundling, of course, that happens. Sometimes we allow both on the same day. So just there, I mean, it could be a number of reasons, but I mean, if I really wanted to tell you specifically why it's being denied, I would have to pull data. But it is a very, very commonly used code. Here's what you need to document for psychotherapy services, including family psychotherapy and group psychotherapy. And here's more information, limitations for psychotherapy. These are those expectations of WPS GHA, what needs to be documented, what's covered, what's not covered. It's included in the policy. All right. Any more questions, Ellen?
Yes, you have mentioned the ABN several times. Does it have to state specifically that the service is not medically necessary?
The ABN instructions are do state that you do need to specifically state why you believe Medicare will not cover the item or service, or why they will deem it as not medically necessary. So you do have to be very description. You can't just say Medicare doesn't allow this more than once in every 6 months. You need to be more specific than that. Medicare does not allow this because based on the policy. Um, there's no uh, there's no reason that Medicare will allow this, more than 6 months. That's not really a great example either. But you do need to be description. You can't just generalize. You have to say why you believe your service does not meet the the guidelines for or the parameters for treatment coverage rather.
Okay, and then the next question is, can you correct more than one item when you're doing a clerical error reopening?
I would need to look at the publication on that. Ellen, do you know that offhand?
If it's one of the items that are listed that you can do on a clerical error reopening, then if it's more than one, yes, you can do that.
Great, thanks for your help.
You're
Good to
welcome.
know. Good to know. I'll tell you, for those people, when I'm presenting live, a lot of times I ask, how many of you use this process? And the hands go up and I say, do you like it? Do you love it? And people say they love it. They love being able to make those corrections on their own or those clerical error uh, fixes. All right.
Okay,
We have about, oh, go ahead, Ellen.
we just have one last question,
Okay.
and it is whether a group therapy and individual psychotherapy can be performed on the same day for the same patient.
The answer is yes. If medically necessary, both can be rendered and paid for on the same day. Now, you're going to need to take into consideration that the information or the need for that would be in the medical documentation. You're also going to need to consider, do you need to append a modifier, and so on and so forth. But yes, we can consider both of those services on the same day. Now, one thing you need to be aware of when the same provider is billing for the same patient on the same day, you need to look at those bundling edits or those procedure to procedure coding edits that are posted on the CMS National Correct Coding Initiative web pages to make certain that Medicare is going to allow both those services on the same day and when a modifier would be necessary in order for Medicare to unbundle payment. And remember that just because it says you can use a modifier to unbundle payment doesn't mean you should use a modifier. It means if the documentation justifies it, you may consider appending the modifier. So just some tips for you to remember. And here we are at the end. We've gone a couple moments over. Thank you for your participation. Our greatest compliment is when our providers or when you recommend our WPSGHA education to others. Please consider doing so to help us reach the greater provider community. This helps us reach our goal to assure that current and effective education is being provided to all of those in our MAC jurisdictions. On behalf of myself and Ellen and all of us in provider outreach and education, I do want to thank you for your participation. We look forward to your survey comments and we hope to have you join us in future events. You may now disconnect. Thanks everyone. Have a great day and happy almost March. Goodbye.